Welcome to this explainer. Today, we are literally cracking open a microscopic invader's playbook. We're going to take some pretty complex medical jargon and translate it into an accessible, step-by-step story of exactly how one specific pathogen infiltrates the human body, wages war, and how we ultimately fight back. We're looking at a disease that has plagued humanity for centuries, but honestly, when you break down exactly how it operates under the microscope, it is nothing short of fascinating.
Okay, let's dive right into this. Here's our roadmap. First, we'll meet the microscopic invader. Then we'll see exactly how it breaches host defenses. After that, we'll track its three distinct stages of warfare, look at the complications and our medical counterattacks, and finally, we'll talk about building your ultimate shield.
All right, Section 1, meet the microscopic invader.
So what we're dealing with here is salmonellosis, or as you probably know it in the severe form, typhoid fever. By definition, this is an acute systemic bacterial disease. Now, systemic is the key word here. It doesn't just stay put in one localized place, it affects your entire body. The specific agent causing all this chaos is called Salmonella typhi. And how exactly does it get in? Well, the organism gains access to your body through the ingestion of food or water that has been contaminated by infected feces or urine. Yeah, it's definitely an unsettling thought, but it's the mechanical, biological reality of how this invader operates.
Let's look at the invader's criminal rap sheet, shall we? These are the defining traits of Salmonella typhi. It is a gram-negative bacterium. It's flagellate and motile, meaning it's actually equipped with these tiny tail-like whips for movement, which allows it to actively swim and navigate through its environment. It's non-sporulating, so it doesn't form protective spores. It's an anaerobic bacilli that survives by fermenting glucose. And perhaps most importantly for us, all members of this genus are pathogenic to humans. This invader is quite literally built to cause human illness. Moving on to Section 2, breaching host defenses. The epidemiology here is absolutely crucial to understand because the clinical course of typhoid fever is almost always a human-adapted salmonella. Most cases can be traced directly back to a human carrier. Transmission relies on what we call the fecal-oral route, primarily through the contamination of water. To put it bluntly, a typhoid patient excretes these bacilli in their feces and urine for about a month. Even infected vomit or pus from abscesses act as sources of infection. So it relies entirely on a breakdown in public sanitation to reach its next victim. Now, what's really interesting about this slide is the sheer math of the invasion. Notice the stark contrast here. A microscopic dose of 10 to the fifth power, that's 100,000 organisms, causes disease in about 25% of cases. But if you increase that dose to 10 to the 9, or 1 billion organisms, the infection rate skyrockets to 90%. It's basically a massive numbers game. The heavier the contamination, the more likely the invader is to successfully establish a beachhead in your system. So what happens once the bacteria actually gets inside? Well, the incubation period usually sits between 7 to 14 days, but depending on the size of that infecting dose we just talked about, it can be as short as 3 days or as incredibly long as 60 days. And during this time, it's executing a completely stealthy breach. Following ingestion, Salmonella typhi passes right through our stomach's acidic gastric barrier. It reaches the upper small bowel, invades the host, and causes a transient bacteremia. But here is the truly devious part. The organisms act just like a Trojan horse. They are ingested by our own immune cells, specifically the mononuclear phagocytes, and instead of being destroyed, they survive and multiply unseen, right inside the very cells meant to protect us.
Okay, Section 3, 3 stages of warfare. The clinical timeline of untreated typhoid fever operates in a very strict chronology of escalating and de-escalating illness. We're looking at 3 distinct stages. First, the prodromal stage, spanning roughly the first week. Then, the fastigium, or typhoid state during the second week. And finally, the defervescent stage that follows. Let's break down exactly what happens to a patient in each of these clinical phases.
During that first stage, the prodromal stage, the patient starts developing increasing malaise, a headache, a cough, general body aching, and a sore throat. They might even experience epistaxis, which is just a fancy medical term for a nosebleed, along with abdominal pain and either constipation or diarrhea. Interestingly, the fever at this stage is generally higher in the evening than in the morning. Physically, doctors might find a slight abdominal distension and tenderness, and maybe a slightly enlarged spleen. But the hallmark visual symptom appears here too, rose spots. These are pink macular spots or papules that pop up principally on the trunk, chest, and abdomen during the second week. They usually vanish on their own after 3 to 4 days.
Then, after about 7 to 10 days, the patient hits the fastigium stage, which is the peak typhoid state. The fever stabilizes, staying consistently high, and the patient becomes really quite sick. You start to see some bizarre and memorable symptoms here, like what is clinically described as pea soup diarrhea, or conversely, severe constipation. There's marked abdominal distension and hepatosplenomegaly, meaning the liver and spleen are noticeably enlarged. In severe cases, the physical toll is just incredible. The patient lies totally motionless and unresponsive, with their eyes half shut, appearing completely wasted and exhausted, though they can usually be roused if you try. Now, if the patient makes it through that peak without any fatal complications, they enter the defervescent stage. This is essentially the vital cool-down phase. Improvement happens, but it's gradual. The fever declines in a very distinct step-ladder fashion, returning to normal over about 7 to 10 days. The patient finally becomes more alert, and those intense abdominal symptoms start to disappear. But, and this is a major warning here, relapses can still happen up to 2 weeks after this defervescent stage begins. The invader might be knocked down, but it definitely isn't fully out yet.
Which brings us to Section 4, Complications and Counterattacks.
So the crucial point here is understanding what happens if this invader is just left completely unchecked by modern medicine. The complications of untreated typhoid fever are devastating. We're looking at massive internal trauma, intestinal hemorrhage, and intestinal perforation, where the bacteria literally burn holes right through the bowel wall. The infection can also spread to cause meningitis in the brain and spinal cord, arthritis in the joints, and pyelonephritis, which is a severe infection of the kidneys. Make no mistake, this is a pathogen that absolutely ravages the human system if it's allowed to. To launch a successful counterattack, doctors obviously first have to confirm the target. They identify the organism through laboratory findings. This means taking stool, urine, and blood cultures to actively grow and identify Salmonella typhi. They also use the Widal test, which is a specific blood test for typhoid. And importantly, physicians have to conduct a differential diagnosis. Because early symptoms like fever, malaise, and a headache are so incredibly common, they have to carefully rule out other diseases that mimic this invader, things like infectious hepatitis, malaria, or pneumonia.
Once we've confirmed the target, we deploy the heavy artillery, antibiotics. Historically, chloramphenicol has been the heavyweight champion here. It's highly effective over a 2-week oral regimen. But, as you know, medical arsenals evolve. Today, the latest treatments lean toward a 7 to 14-day course of ciprofloxacin or ceftriaxone, with amoxicillin serving as a very reliable alternative. These drugs act as precision strikes inside the body, shutting down the bacteria's multiplication and finally ending the internal siege.
And finally, Section 5, Building Your Ultimate Shield. Preventing typhoid fever actually connects massive, large-scale community infrastructure right down to your everyday individual actions. Just look at these steps. It starts macro, proper latrine construction and ensuring an adequate, clean water supply to entirely sever that fecal-oral transmission route. Then comes health education and the active identification of patients, carriers, and food handlers who might be unknowingly spreading the bacteria. But at the very bottom of this list is perhaps the most massive power of all, basic personal hygiene and rigorous hand washing. We've tracked Salmonella typhi from its criminal profile through its clinical warfare all the way to its ultimate defeat. But I want to leave you with this provocative thought. How does our everyday infrastructure and something as incredibly simple as washing your hands truly protect us from these invisible invaders? You see, understanding the invader's playbook is a great first step to victory, but it is our consistent daily hygiene that serves as the ultimate shield. Keep washing those hands, and as always, stay curious.